And hello to everybody who is watching this early morning. I know some of you guys are watching from the East Coast, so it's even earlier for you guys. So I just want to introduce Dr. Wideman here, who's we're going to show his presentation first. He's a physical therapist and assistant professor at McGill University in Montreal. The overarching goal of his work as a clinician, researcher, and educator is to improve the clinical care offered to people living with persistent pain. He has aimed to cultivate a comprehensive perspective on pain throughout his training and clinical experience. Dr. Wideman has received several national awards for excellence in research and clinical education and has presented his work in the leading international conferences and in journals in the fields of pain and rehabilitation. So welcome, Dr. Wideman, and I see that you have something here to show us.
Yeah, you told me to bring something that's important
a little
to me.
person.
And yeah, this is little Esme.
Hi, Esme.
She is almost 4 months. Yeah,
born
in the middle of a pandemic. Yeah, and I'm not sure if she's really
can
paying
she
attention to you. I
process
think
the
she's
screen?
looking at herself.
Yeah, she's like,
it's a good litmus test. This is her first time on a camera.
She's adorable. So now I can hold her. I can hold her while we play your talk, right?
That's right. Yeah, I'll just pass her through, of course. Yeah. This is the one perk of working at home, is getting to be a little bit closer to my second daughter.
Wow, second one.
Yeah. You'll probably hear the other one too in the background. 4 years old is my first.
Oh, she's beautiful. Look at that head of hair.
Yeah.
All right. So thank you for sharing your beautiful baby girl. And I guess we will go ahead and play your presentation.
Hi there. My name is Tim Wideman, and welcome to my presentation called How to Think About Pain. The goal of today's talk is really twofold. First, I really just hope to get folks thinking about what is the nature of pain. And then second, I'm really hoping that you can get some food for thought in terms of how to best orient your clinical practice to this understanding of pain. So to do that, we'll focus on three different aspects through the talk. The first will really kind of summarize 3 points on pain. So these will highlight 3 different aspects of what pain is. And then also profile some of the kind of fundamental challenges that those can bring to clinical practice. Next, I'll introduce a new conceptual model that I helped develop. And the last part is really kind of focusing on some potential considerations and implications for clinical practice. So the first of the 3 points on pain is that pain is impossible to observe. And when you think about how you can tell when someone is in pain, or what kind of clues might give you an idea that somebody's in pain, there's a lot of different things that we can use to infer the pain experience. So we could look at somebody's pain behavior, look at their facial expression, look at how they're acting. We could talk to them. We could ask them if they're in pain. We could have a conversation about that. We could have them fill out different self-report questionnaires. We could also, if we were a bit more perhaps research oriented, we could poke them, we could heat them up and look at how they react. We could also scan their brain, take blood, analyze it, look at their genetic makeup, and a range of different things. All of this data can give us clues as to whether or not this person might or might not be experiencing pain. But if we raise the bar a little bit and we switch to just, how can we infer that somebody's in pain, to actually how can we know with 100% certainty whether somebody's in pain, the question becomes a little bit more complicated. So thankfully, we're not the first people to consider this question. There's a 20th century philosopher named Ludwig Wittgenstein, who developed a really interesting thought experiment to kind of tackle these types of questions. And so his thought experiment was called Beetle in a Box. And in this thought experiment, you basically have a scenario in which everybody has this special box. And it's special because you can open it up You can look in what's inside, but even though everybody has this box, you can't look inside anybody else's box. So you can only have access to your own, the contents of your own box. And now imagine a scenario where everybody has these kinds of boxes and everybody calls the contents of their box a beetle. So there's this shared word, shared vocabulary for understanding what a beetle is, but the definition of that word is really based on the contents of your box, which might differ from somebody else. And so in this scenario, you have the same word, but a potentially unique meaning for that word. And Wittgenstein was using this thought experiment to really kind of like highlight some of the problems related to language and to pain. And so basically, if you replace the word beetle with pain, it's essentially our scenario with the pain experience. Pain is fundamentally not something that we can see directly in somebody else, but we each have our experiences that we can use to kind of anchor to this word of pain and use that kind of shared vocabulary. And so if we come back to this idea of a beetle in a box and the inherent black box nature of pain, and we ask the question, how can you know when someone else is pain? Well, if we're anchoring our definition of pain in the ISP definition, where we really anchor it as an experience, then really we can't know whether or not somebody else is experiencing pain, simply because we can't directly observe it, and we can't kind of generate any data that would conclusively confirm or reject the report of pain. And that relates a little bit to the experience of this lovely lady whose name is Jo Cameron, who's in her 70s and lives in Scotland, and was in the news a lot over the past year because she's an individual that apparently has never felt pain and doesn't have the capacity to really kind of experience pain. And so she's gone through her life. She has had delivered 2 children. She's gone through a number of different surgeries for kind of advanced arthritis, and has never experienced pain in all of those, and didn't require any kind of analgesics either to navigate those kind of scenarios. And what's interesting is that if you think about this beetle in a box paradigm, she uses the word pain and she relates to other people who have pain, but has never experienced that herself. And the way that she would understand this is that she just kind of thought that her threshold for pain was a lot higher than other people. And so she'd have these kind of interesting scenarios where she would give her friends advice about child delivery and really kind of downplay any kind of difficulty that childbirth has, and kind of reassure her friends that it's really not as bad as people would say. And I think what's really interesting about this is that I think it's an extreme example, but is broadly representative of how we think about pain. We often make the assumption that our personal experience of pain are basically similar to other people's experiences, maybe our patients' experiences. And there's really not a great amount of evidence to suggest that that's actually the case. Because when we think about pain, we know there's a whole lot of individual variability. And there's people that are high on that spectrum in terms of sensitivity, and also kind of low on that spectrum in terms of sensitivity. And so it's important as a starting place to probably recognize our limitations in not being able to fundamentally kind of observe or really kind of know our patient's pain experience. But this raises the paradox then, is if pain is really kind of fundamentally non-observable, then how do we relate to our clinical practice? Because basically we need to make observations, we need to use measurements to kind of advance treatment and to kind of manage pain. And so the question is, this paradox is we have this non-observable phenomenon, and yet we depend on observations for its management. And so the key question here that we'll circle back around to is really which observations related to pain, of all the different ones that we talked about, should we rely on to identify pain and then also to kind of inform its clinical management? And that's a question that we'll circle back around to when we come to their different strategies. The second point on pain is that pain is sometimes a symptom, but always an experience. Let me talk a little bit about what I mean by that. So first, when we talk about symptom in the broadest sense of the word, we're thinking of it as something that it is pointing towards something else. So it's indicating, it's providing evidence for the existence of something else. And so in the broadest terms, we can think about pain symptoms as basically being an expression of some sort of mechanistic process. And this relates a lot to how most of us are probably trained to view pain. Our training typically focuses on contextualizing pain as a symptom. And if your training was a little while ago, then probably the symptomology of pain was really anchored in tissue damage. So the idea that when you have a lot of tissue damage, you have more pain. When you have less tissue damage, you have less pain. And if it's a bit more contemporary, if it was a bit more recent, then you're probably viewing pain as an output of some sort of central nervous process. What's important to appreciate is each of those paradigms could broadly be constructed as viewing pain as a symptom. And so basically we kind of think about pain as being evidence of some sort of mechanistic process like tissue damage or central sensitization. And so in this context, pain is really viewed kind of instrumentally for what it's kind of pointing towards. And that's really helpful. Viewing pain as a symptom is really what brings us towards differential diagnosis. It really helps us identify different targets for treatment. And it also helps us evaluate the efficacy of those treatments. So if we want to bring symptoms down, then we can kind of circle back around to them, look at our measures, and see if we've done that or not. So there's some real value in kind of thinking about pain in this mechanistic or symptom-based way. That said, it's really not exactly in line with how we define pain. So when we look at the ISP definition of pain, even the updated definition, it's really anchored in the idea that pain is an experience. And the note on pain goes further and kind of really emphasizes that pain is always a personal experience. And when we think about anchoring pain and viewing it as an experience, we need to remember that even if we can't make sense of its symptomology, if we can't understand a potential process that's underlying the reports of pain, it's important to recognize that patient still has that kind of lived experience of pain. And the lived experience of pain, really what I'm talking about is how the patient actually feels when they're in pain, how it affects their life at the most broad level, and also kind of how it affects their sense of self or their sense of identity. And the value of viewing pain as an experience is this can be a really important place in terms of connecting with the patient. So developing an understanding of what they're going through, developing a therapeutic alliance, and also kind of better engaging a patient in treatment by better understanding and addressing their concerns, their priorities, their needs, and also kind of tailoring treatment towards those as well. And so what we see are these two perspectives on pain that we can take. We can kind of view it as a symptomology that kind of helps us understand a potential underlying mechanism, or we can kind of look at that experience directly and understand the life impact of it. And each of these are kind of anchored in our different biases. So as a clinician, we're probably grounded mainly in the symptomology of pain in terms of our training, versus the person who's living in pain is interested in that. They're probably interested in why they have pain and what can be done about it. But they also have this very real lived experience of pain. And so it's important to, as a clinician, to try to find a balance of these two perspectives. So the fundamental question that we'll be circling back around to there is how can we find a balanced perspective of these? And if there's discrepancies between, let's say, a patient's pain report of their experience versus the presentation of the collection of symptoms they have, how can we navigate any potential discrepancies between those things? So the third and final point of pain that I'll be talking about just briefly is that pain changes everything. And this will probably be obvious for folks that are immersed in the pain world of either research or clinical practice, or maybe you're living with pain. But pain really has this potential for, if it sticks around, really kind of changing big parts of our body and then also our lives. And so when we see this probably most dramatically when we look at central nervous changes in relation to pain chronicity. And so if we look at imaging data of groups of people that are living with pain versus not living with pain, we can simply look at the structure and function of their brains and kind of infer which group they would fall in. And those changes are largely a result of kind of living with that pain experience. But in addition to changing how our body works, it can also change important parts of our life. So it can change how we think and feel. To illustrate that, what we see is just really large numbers of people who are living with pervasive depressive symptoms that are often quite severe. Similarly, it can change what we do. So if we look at reports of work disability, we have up to about 40% of people in the US who are reporting pain that also report that their pain is restricting them from doing things like work. It also changes in probably the most profound way, how we can view ourselves and our relationship to the world. And we see that most dramatically in the increased rate of suicide and suicidal ideation amongst this population. And so people living with pain, unfortunately, are twice as likely to report suicidal behaviors compared to those who are not. And so what's important here is that pain can have a really dramatic impact on not only our bodies, but also other aspects of our life. And the key question here is, how can we assess and address these types of changes in meaningful ways in our clinical relationship with our patients? So 3 points on pain, 3 challenges related to pain. So just to summarize, if pain is fundamentally unobservable, then which observations should we use to kind of identify and inform its management? If pain can be viewed both as a symptom and experience, how do we find a balance between those 2 different perspectives, particularly if there's discrepancies between them? And if pain has this big life impact that's often associated with suffering, how do we meaningfully kind of access and address this in our approach to care? So to get at some of the strategies to address these issues, what I'd really like to do is introduce this kind of conceptual model. So it's called the multimodal assessment of pain model, which is the MAP model. And the intention here is to kind of bring in some of those core attributes of pain that I mentioned. So specifically that non-observable nature of pain, and kind of really bring in the clinician and patient perspective on that. And so hopefully it provides this lens of how we can kind of view pain in different ways, and then also provides a lens for addressing some of the challenges that I mentioned earlier. Importantly, this doesn't reconcile the paradox of pain. Pain will always be a non-observable phenomenon. It doesn't take that away, but rather it tries to offer some pragmatic strategies for working within the inherent limitations that we have. So I should mention that, that this conceptual model, we published a paper outlining it and detailing a lot of the aspects that we'll be talking about. So that was published last year in the Clinical Journal of Pain. That's an open access article that you're free to download. And I just want to highlight here that this work was really in collaboration with a number of really excellent researchers, Rob Edwards, Dave Walton, Mark Martel, Anne Hudot, and Dave Siminovich. And so just wanted to recognize all of their contributions in kind of putting this work together. So this is basically an image of the MAP model, and I'll walk you through the different aspects of it. The core aspect here is really that third-person perspective. And so the model is really developed from the perspective that we would take as a clinician or from a researcher. And in keeping with that, we've kind of coded that pain experience as a black box, similar to that beetle in a box paradigm, where we're effectively kind of blinded to that experience. We're unable to kind of observe it as a third person. And moving on from there, we basically have around that black box is this kind of sphere, which we identify as the pain expression. And so those are basically the words that a patient would use to describe their pain, and the behavior or what that patient does in relation to their pain. And that's the sphere, those 2 different colors around that pain experience. And then these funny shaped cones here are basically the measures that we would use to assess pain. And so those include self-report measures, the questionnaires that people would fill out, and then also non-self-report measures such as brain imaging scans or blood work, things like that. And finally, encompassing all of that is the environment. And the understanding here is that the environment can shape all the other aspects of the model. So it can shape the pain experience, but also the different expressions of pain, and certainly our measures as well. So two different perspectives. So this kind of perspective really shows the relationship between the clinician and the patient. And this perspective is really kind of viewing the model from the clinician perspective. And so the idea here is that the pain experience without this cutout is kind of blinded to us. It's a black box to us. So this leads us to two different applications, so two different considerations for clinical practice. So the first one is the importance of divorcing how we validate pain from how we approach its management. And so this is really anchored in the idea that pain is not observable, but yet we have all of these different observations and measures that might relate to it. And so it kind of relates to the question of how we should identify and use that information to identify and manage it. And the problem that it's addressing is the idea that too often we kind of conflate the validation of pain with its management. So what I want to do is just kind of give you two examples of how we might do that. And they're really just kind of characters of clinical practice, just to kind of try to get you thinking about this idea of collapsing the identification of pain with its management. So the first one is if we take kind of a mechanistic approach or a symptom-based approach to looking at pain. And so here, basically, in the context of pain reports, we would look at this, and we would really try to be looking at pain symptoms and asking whether or not they make sense in line with our understanding of what could be causing them. And if they do, then we would align our treatment with that. But the flip shot of this approach to pain is that if they don't, then we really kind of aren't offering any kind of treatment. And not only that, but we have a tendency potentially to dismiss those kind of reports of pain as somehow illegitimate. And so what we know from the literature is that there's a large literature base that suggests that patients with unexplained pain are most likely to experience stigma. And they're most likely to feel that their clinicians are not taking their pain seriously, and are also kind of like implying that it's fake in their head or being reported for some sort of secondary gains or advantages. And so the idea with this approach is only treating and legitimizing pain that makes sense to us, if that makes sense. And so the risks associated with that is that there's a risk of not validating a legitimate pain experience, and also kind of stigmatizing our patients, and through that kind of undermining engagement with treatment and undermining outcomes of treatment as well. So that's one approach in which we conflate identification of pain with its treatment. The other approach I call a compassion-based approach to pain management. And this is really kind of anchored in patient-centered care. And it's anchored in the idea that all pain is real. And the idea that this is anchored in is really kind of taking a lead from our patients in terms of what their preferences are and what they're looking for in terms of pain management. And so all pain is real. All treatments are applicable as a result of that. The challenge with this approach is that it can take us down a road in which we might be more likely to consider treatments that we really don't feel are warranted, or we don't feel that there's a good evidence base behind them, or that will do much good in relation to kind of our professional opinion. So things like advocating for work disability or offering opioids for pain management as a result of that. So each of these kind of approaches has a tendency for kind of conflating the validation of pain, which is management. So in the first approach, the idea is only treating pain that makes sense. And the second approach is because pain is real, all treatments should be applicable. And each of those is corresponding kind of with their problems. And so the idea here is that each approach has their advantages and each of them has their limitations. And so the challenge is maybe trying to carve out a bit of a middle ground. And that's really what this strategy of divorcing the validation of pain from its management is grounded in. And so the idea with this kind of map approach to this question is it really splits it into two different questions. So two questions of one, how do I identify real pain? And the other is basically how I approach its management. So let's tackle the first question. The first question, how do I identify quote unquote real pain? And the answer is really we can never know with certainty, because pain is really kind of a black box. And so effectively we kind of have this choice to make. We need to kind of either make a choice of believing all of our patients that report pain, or really kind of not believing any of our patients that report pain, because there really isn't more evidence to it that could allow us to determine on an individual basis if these reports are true or not. And so the MAP strategy is really to validate our patients' reports as legitimate and real. And so if we're asking a question of how do we identify a patient's pain as real, we simply ask them. And then the pain narrative, which is that first sphere, that's basically the words that the patient are using to describe their pain, their own words, is really kind of seen as the best available proxy for that non-observable pain experience. And the implication of this is that all pain that's reported is regarded as real. And that's kind of anchored in that compassionate approach to care. And the kind of rationale with that is that there's really kind of no evidence that you could provide that would disprove a pain narrative in any kind of conclusive way. And so in line with the idea of medical ethics, of supporting our patients' autonomy, of what they report their feeling as being accurate, and also in line with the declarations that the ISP has made about validating pain reports. The rationale for this kind of pillar is anchored there. The second question is really kind of a broader one, and it's asking the question of what information should I use to manage pain? And here, the question of what information would be valuable is really kind of all information would be helpful in helping us guide treatment decisions. And so if we think about the words that our patients are using or the behaviors, that can be really valuable in understanding the personal pain experience, giving hints towards that. The pain measures can be really useful in terms of classifying pain, understanding its mechanisms. And the environmental factors can really kind of help us understand context and how it's shaping that experience. And so all of this different information related to the MAP model as it's portrayed is really helpful in answering the question of why my patient is reporting pain. And so the MAP strategy is really kind of advocating trying to use a triangulation approach to kind of thinking about all these pieces of evidence and kind of what explanation they lead us towards. So the idea of it helps us generate an explanation of pain, but also kind of a diagnosis and classification, and helps us inform treatment decisions. And that's kind of really that approach of triangulation and kind of towards that explanatory paradigm is really kind of anchored in a mechanism-based approach to management. And so if we circle back around to these challenges, basically this is kind of most directly related to that first one. And so the idea here that pain reports are used to identify pain in a really simple way, versus all of the assessment information is used to kind of guide its management. So those two things are kind of divorced from one another. And what I want to do is I really want to recognize that validating reports of pain is not always easy. We'll always have patients where that might be challenging. And there might be a number of different factors at work that make that challenging for us. And so I just want to give a couple of different strategies in terms of how you might want to think about that in the face of those kind of challenges. And so the first one is really kind of just reminding ourselves that really at a fundamental level, we can never be sure that a patient's pain doesn't exist. And so the idea here is that we're not holding the experience of pain, the legitimacy of that experience, as a hostage to its symptomology. So even if its symptoms don't make sense to us, even if we're not able to come up with a reasonable explanation for why these pain symptoms are being reported, it's important to still have a place where you can legitimize that pain experience. The next is really trying to reframe pain as an experience rather than kind of viewing it as a symptom or a diagnosis. And the corresponding example here is the difference between sadness and depression. And so what you can imagine is kind of doing a workup for a patient and coming to the conclusion that that patient does or does not meet the criteria of clinical depression. But even if that patient doesn't meet the criteria of clinical depression, you wouldn't then circle back around and challenge the reports of sadness. You wouldn't say, oh, I've done this evaluation and it turns out that you're not feeling sad. And we don't do that because we think of sadness as a feeling, and we think of clinical depression as something that meets a diagnostic criteria. And in a way, we can think of pain in that same way. Pain is an experience, and we can accept it at face value, even if we're not kind of meeting the diagnostic criteria for the different mechanisms or different classifications that we would be able to identify. So thinking about pain a little bit more like sadness rather than a diagnosis of depression. And the third one is just kind of reconsider why patients might be making dishonest reports of pain. And so what I want to identify here is that it's completely possible that somebody might report pain to get off work, to get money, to get drugs. That's completely a possibility. And there's really kind of no way that we could identify if that's the case or not. But what's important to appreciate here is that if somebody is doing that, if somebody is kind of making dishonest reports about what they're feeling in order to kind of have these gains, there's a real strong potential there that that person is suffering. And so the idea that you might want to do as a clinician is to kind of focus on that potential for suffering and to try to have a compassionate response for that. And also try to find some therapeutic avenues either that you could do or that maybe a colleague in another profession might be able to do to help alleviate suffering in the broadest sense of the word. So if you're having trouble kind of getting behind the idea of pain with this patient, you might want to get behind the idea of the potential for suffering and trying to alleviate that. Okay, so moving on to the second example, and this is basically the second clinical consideration, and this is really trying to seek to understand and address suffering. So a little bit related to the last point that we just made. So suffering is something that as researchers, we often spend a lot of time talking about, but actually we don't really kind of do a lot of research that directly looks at pain-related suffering. And so if we look at some of our foundational models, we see suffering as an important construct in that. So this is Lozer's kind of onion model of pain, which is an image you've probably come across before. And suffering has a central place in that model. But we really haven't done a lot of work beyond that to kind of like really understand this construct and how we should best get at it. What we do have is a bit of a definition of suffering, and I have some core ideas on suffering that I'll share with you, and then I'll offer some suggestions on how you might want to address this within clinical practice. So this concept of suffering that Lozer first presented in this model was really anchored in Eric Cassell's work on suffering, which is really fascinating work, and it has a lot of depth to it. And the idea that Cassell had was really to kind of conceptualize suffering as a threat to one's sense of self, to a sense of identity or autonomy in different ways. And the way that Cassell conceptualized suffering was really kind of viewed it more as a problem related to the experience of pain and how pain kind of fit into our lives and the problems that might cause, more so than its kind of symptomology. So independent from how intense pain was or its symptom-based characteristics, suffering was really kind of grounded as a lived experience problem, if that makes sense. And so the question then is how we get at this lived experience. And the MAP application for that is really kind of highlighting that the narrative, so really kind of listening to what the patient is saying about pain, is really regarded as the best way of accessing that kind of pain-related suffering. So the question is why? Why is this the case? So what I'd like to do is give a little bit of time here to let a colleague of mine who's much better equipped to answer this question talk about her experiences in terms of why something like a narrative rather than a 0 to 10 scale and measurement might be important for accessing pain-related suffering. So this is a colleague of mine who's lived with pain for decades and also happens to be a physical therapist and an educator and really kind of knowledgeable about talking about her experiences and relating it to clinical practice.
Well, when they ask me that question that they all ask, how intense is your pain? What answer will I give?
Right.
If I say it's a 9 on 10, they're likely to think, okay, she's an exaggerator. If I say it's a 3 on 10, they might think she can deal with that going to see someone locally or whatever. She doesn't need to come here. So I really thought a lot about what answer I would give them.
Right.
And they did ask, and I don't even remember what answer I gave.
Right.
But that was scary going in. And when they asked the questions about what made it better, what made it worse,
Right.
You really think of what answers you're going to give to these questions, because the thing that's most in your mind is that I want this person on the other side to understand my suffering and what I'm going through. Mm-hmm. And so they must have preconceived notions, and so how will I answer truthfully, because I don't want to not be truthful, but most of all I want them to believe me.
That's really interesting. So help me understand this process of thinking about what number. So can you tell me a little bit more about that? So why is that a difficult process? I can understand thinking about what other people how they're gonna perceive that, but for you just to provide a number, can you talk about if there's difficulty there?
I don't like that number business, just because I've been asked it so many times, and it's like you have to stop and think, okay, what is my pain on 10?
Uh-huh.
Okay, 1 would be, 2 would be,
Right.
3 would be, and it's just such a little number.
Uh-huh.
And my pain is like here and here and here and here and here, and so a number doesn't justify it. It doesn't, and you ask me and I might say 4. When I come back 2 days later and it's a little more, is it really 2 more than it was?
Right.
Is it 1 less than it was?
Right.
It's just, these are arbitrary numbers.
Right.
And my pain just doesn't fit into that.
Right. So if I'm understanding correctly, when you're on your own and you're not being asked by a clinician about your pain,
Yeah.
Are you inclined to think about it in relation to numbers?
No.
No.
No, I never think of it in relation to numbers. I think it's sorer than it was. Today's a harder day than it was. Today is an easier day, but I never think of it in terms of numbers.
Okay. So it's almost like this translation process.
Yeah, it's hard for me. I mean, I guess it's meaningful on the other side, but sometimes I think, is it meaningful?
Right.
Because if you were just to look at my pain and, I don't know, I guess I would give you a lower number if I was starting to feel better, so you could say, yeah, it's better, but it just isn't so meaningful for me.
Right.
So I don't want to assume that most people here are living with pain, and I want to try to help you get at this idea that was talked about in this video of kind of translating a personal experience into these numbers. And so I want to engage you in this little thought experiment, which is really kind of an experiment in love. So the first question is have you ever been in love? And if you have, what I want you to do is kind of think about this experience of love. And if you haven't ever been in love, that's okay. What I want you to do is kind of think about somebody who you know who has been in love. And I want you just to take a moment to think about how being in love, how that made you feel, how it maybe affected your thoughts, how it affected your different behaviors and what you did, and how it affected your relationship with other people. So think about this experience, think of all of the different kind of permutations and how it impacted your life. And now what I want you to do is I want you to come up with a number. I want you to rate your intensity of love. 0 is no love, 10 is the most love you could ever imagine. And I want you to go ahead and pick a number between 0 and 10 to really kind of capture that love experience. And the question is, how well does that number kind of capture that experience for you? So imagine, heaven forbid, that we've just kind of lived through this a global pandemic, and you're reuniting with a friend in a coffee shop after this pandemic has ended, and you're really excited to see them because you're in love, and this is a new thing, and you're really kind of excited to share this experience with them. And so you sit down in this coffee shop, and you start to kind of narrate what you've been going through, and a friend says, whoa, hold on a second here. What's your rating? What's your number? And you're like, geez, this is a pretty big experience. I'd give it about a 9 out of 10. And imagine your friend kind of stood up and left at that moment. How well do you think they would have of an understanding of what you're going through and kind of living with? It's a little bit of a silly metaphor, but pain and love are kind of interrelated in a way, because they're both these kind of really complex, non-observable experiences that we can't directly measure as clinicians. And so the idea here is that while measures are kind of have an essential place in our clinical management, they inherently rely on this translational process where the person has to take this experience and code it into these numbers that sometimes feel a little bit arbitrary for some patients. And not only that, but they're really narrow. So if we look at this diagram of this map model, the reason why these cones are kind of narrowing is they're trying to illustrate the narrower nature of them in relation to that rich narrative. And so when we allow a patient to use their own words, they're really going to be in a better position to talk about all the different idiosyncrasies about this experience to them. So I'd be much better equipped to tell that friend in a story or through my own words about how this love experience has affected my life. And I think that's what we see in the video as well, in that this person is saying that that only using a number is restricting their ability to communicate. So pain can be viewed both as a symptom and experience. How do we find a balance between these two different perspectives and recognizing any potential discrepancies? And so the idea here is that most of us are probably most well-versed in kind of looking at the symptomology of pain. And in order to find a balance there is we probably need to shift our focus a little bit to look at the experience of pain. And to do that, we really kind of need to use that narrative. We need to kind of uncover what the patient is going through. So what I want to talk about briefly just before we wrap up are different strategies that we might want to use to address suffering. And as I mentioned before, there's not a ton of literature on this. So these are kind of my best advice for basically how you might approach navigating suffering. And it's kind of anchored in what I teach students, which is what I'll profile first, and then I'll just kind of give it a little bit of food for thought for more experienced clinicians. And then after that, we'll just kind of wrap up. So basically what I do with my students is I kind of give them different themes and challenge them to try to get at these themes in their subjective evaluation for people with pain. So these themes are ranging from, talking about how pain has affected their patient's sense of identity, how it's affected their relationship with others, how it's affecting their thoughts and feelings, their activities, their coping, their expectations. And so the idea is that they're addressing these themes in their clinical practice with every patient that they see. And of course, that doesn't necessarily mean that there's a lot of depth in each of those conversations they're having, because that's going to be a function of how pain has affected their life. And so the idea is that the student is learning how to tailor their questions to really kind of align with the life impact of their patient. So they broach the subject that's required of them, but then they kind of use probing questions to get at that depth if it's there, or move on if it's not. And so the idea is that subjective exam becomes a little bit longer for patients that have more of a life impact related to pain. And every time that I kind of focus on this, students can get a little bit apprehensive. So particularly talking about things like thoughts and feelings, or how pain has affected somebody's sense of their life, those can be really intimidating ideas to broach, and sometimes make students feel quite uncomfortable. And so that relates to the acronym that's used here, which is I outface. And so the idea with outface is it's a bit like a staring down, a little bit like a Western kind of stare down. And so I'm kind of challenging my patients to kind of recognize their apprehensions related to broaching some of these subjects, but really trying to outface them in terms of broaching those subjects, even though they might make them feel a bit uncomfortable. In terms of advice for more experienced clinicians that are working in primary care settings, what I would say is really try to ask the question of what are the most important ways that pain has affected your life? And try to ask that question in a way that's not just restricted to your scope of practice, so not just anchored to the tools that you have to address pain. And that's really important because, again, pain is such a broad experience and can have a lot of different permutations. And really, as a primary care provider, you need to be able to triage and assess. So basically, if a patient has the place to talk about what's most important to them, then at least you'll be in a position where you can listen to that, understand it, and then help get somebody else involved who might be better suited to address that if you're not. This also involves kind of taking time to listen and understand the patient's pain story, and really to kind of explore how the pain has impacted their lives. And so this relates to the third challenge that we talked about. If pain has this kind of major life impact, how do we meaningfully address it and access that? And really the narrative is key there. We're really kind of using that to broach the life impact of pain and really trying to understand the suffering experience that a patient might have. So just to wrap up, we had kind of 3 key points and then 3 kind of related strategies to those. So one, pain is really kind of this fundamentally non-observable experience, which means that it's really kind of not, doesn't make any sense to kind of invalidate our patients' reports of pain. And what we ought to be doing is really kind of separating how we legitimize pain, and that should really be anchored in what our patients are telling us. And then we should also kind of use all of the information that our patients are providing us with, marry that with our professional expertise and research evidence to really try to direct our patient care. Second is that, while it can really be useful to kind of look at pain as a symptom, it doesn't always make sense as a symptom, but we also always need to kind of recognize that experiential nature of pain. And so it's partly kind of finding a balance between these 2 perspectives. And for most of us, that will be unpacking what that lived experience is for that patient. And lastly, recognizing that pain often has this massive life impact that's often associated with considerable suffering, and really kind of letting the patient have a space to share their experiences in a narrative fashion, unpacking that experience, listening to that perspective is probably going to be the best avenue for understanding and addressing their suffering. That's it. I hope you enjoyed it, and I'd love to hear from you. Please feel free to stick around and chat, and if not, send me an email, and we'll connect soon. Bye now.
You have a question from Evie Martin. Let me just cut it and paste it to the screen. So Evie says, sometimes I'm conflicted about asking people about their lived experience. Is there a point at which it's best to steer the conversation away from the patient's pain experience?
That's a good question, and I find when I'm talking with students, they often kind of struggle with this balance in terms of how much emphasis to place on it. And my sense is that it stems from this feeling that sometimes patients can be talking about a lot of the same things again and again from their perspective. But I think that really kind of right at the beginning of assessment, doing a really good job at taking time to listen, taking time to kind of really unpack how pain has affected the person's life will just really provide a really solid foundation for the rest of treatment. And that even means that if you need to redirect their focus, then you might.
Oh, just a second, folks. Sorry about that. Oh, Peters, you were in the middle of your question there, Dr.
You want me to start
Wideman.
again?
Yeah, so I'll show it again here real quick. Evie just asked about being conflicted, about asking people about their lived experience. Is there a point at which it's best to steer the conversation away from the patient's pain experience? Oh, and he's frozen again. He'll come back. There you are.
Try it one more time. I got the question. Yeah. Just keep disappearing and coming back.
Yeah, sorry about that, guys. It's just technology. So
yeah. So the short answer from my perspective is really what I think is essential is that right at the get-go, as early as possible, you're giving the patient a lot of space and support to share their story about pain and really to kind of unpack how it's affected their life. And then that might cover a lot of different things. And as a primary care professional, it'll give you a lot of tools to figure out where your scope is, if you need to bring in other clinicians. And then what you'll be able to do later on, and I think this question kind of gets at that tension a bit, is that you'll be able to kind of help focus that conversation. So it's not that you always have to keep talking about all the different ways that pain has affected different aspects of life. You can bring focus to that. But I think particularly as a primary care provider, it's really important that you have that comprehensive understanding early on. And that'll give you license to kind of focus your therapeutic relationship and management strategies, and also help you bring in other professionals as they're needed.
Cool. I'm glad you got to finish the question.
Yeah, me too.
So we actually have another question, and this one is from Jessica Bayless, and it's a little long, so I'm going to show both. But my question is, I'd like to share my approaches with my clients to bring them in on how I work and what models I use. To what extent would you share the MAP model, and what do you think the benefits and limitations of doing so would be?
Yeah, that's a great question. I've actually, since I've been kind of sharing this with other folks and giving presentations, I've come across clinicians that have done just that, where they've actually kind of, and particularly the figure, they've shared that with their patients, and they found that was a really useful tool for them. And I think it's completely up to you, and it kind of whatever matches your style the best. I think that the model is really written to help provide clinicians with kind of some first principles in terms of how to approach pain. And so the idea is really kind of providing a foundation for how we can get on our patient's side, how we can kind of best listen, understand what they're going through, where our limitations are in that, and some strategies to do so. So it's really not prescriptive in terms of how you use it. So basically what I would say is if it's working for you, that's wonderful. And if you're wanting to share it with a client, that's also wonderful. And what I would whenever I do that with a client, I think the way that I'm presenting that is not from a definitive perspective, but kind of like sharing it as almost as a peer, if you will. And so it's kind of not saying that this has to be the way that we think about your pain or the way that it dictates our relationship in terms of how we're navigating pain, but this is one model to understand that. And so you're kind of bringing them in to the idea of kind of validating that and whether or not it's going to be a useful tool for you or not.
She actually has a second, slightly less relevant question. I'm not sure what this means. Do we know anything about whether Joe Cameron feels any emotional pain?
Oh yeah, so Joe Cameron is somebody I referenced in the talk, and she's an older woman. Yeah, no, that's okay. An older woman from Scotland who, if you remember, basically has never experienced pain, and this is kind of a real scientific discovery. And what's incredible about it is that it was only kind of realized later in her life. She only realized really that she was different from people in that respect later in life. And so the question is, does she feel, was it the question just emotion or emotion related to pain?
Let's see, let me pull it back up. Whether she feels an emotional pain.
Emotional pain. So, so first, I just want to challenge that term a little bit, emotional pain. So the way that we think about pain, it's the word "and" that is really key about it. So it's the sensory and emotional experience, and often we want to like tease apart those two things, but then it's not pain anymore. But with Joe, it seems like from her reports, basically that from an emotional perspective, just in terms of her life, she doesn't kind of feel the extreme highs and lows that she understands other people feel. So she doesn't feel like ecstasy and joy to the same degree that other folks do. But then she also doesn't kind of get down and kind of have some of those lower emotions that other folks do. And with pain, she just doesn't. She's never had an experience that she would call pain, and she's had multiple surgeries, multiple children. A lot of experience that other people would associate with pain. So no, she doesn't feel pain, which is including both that sensory and emotional component. And she also doesn't seem to have that kind of high and low range of just like everyday other emotions, which is really phenomenal, which is really interesting.
Cool. I'm actually going to probably extend the Q&A just a minute or two longer, just because of the little freezing thing. We have another question from, I believe this is from Sandy Hilton. What tips do you have for providers who want to encourage people to speak about their lived experience with pain and are short on time because of their organizational constraints?
Yeah, so that's a massive challenge, isn't it? So even if we are on board with kind of having a person-centered approach with care, we want to do listening, we want to do that assessment. There can be environmental constraints that really kind of in a meaningful way and a profound way limit us in doing that. So there are really like no easy answers here. And I think you have to kind of figure out some strategies that work for you and your environment and for your patient population. That said, I think being frank, I think saying, hey, I'm really unfortunately kind of limited on time. What I want to do is I want to figure out what is most important to you, and you can kind of lay that out to your patient so that they have a sense of that context that you're in, and they'll be the best person to kind of prioritize what is most important to them, and then giving that space where you're, even if your time is short, that you are listening to the response. And I think just as important as what you're saying to your patient is the tone in which you're asking it. So if you have body language that doesn't communicate that you're kind of open and eager to listen, I'm just gonna. I think I was just cut off at the end there. Yeah. So I'll just wrap up with that, and basically, tone is just as important as what you would say. And so I think making sure that you have a tone that communicates that you are supportive with your patient, and that you are eager to hear what they say.
Cool. So we have another question, and again, I just want to let the viewers know that we are going to extend this just a couple minutes extra longer. And then, hold on. Sorry. Somehow there's like feedback. Okay. So we will go into the next question. We have a lot of good questions coming in here that I've been cutting and pasting. So the next question is from Matt Foster. Do you feel in an effort to emphasize and understand a person's suffering that you end up taking your work home and over-personalizing the patient's story? This was a trouble of mine early in my career. I won't show, there's the end where it says career.
So I think I got the question, and if you're okay, I'll just try to answer it the best I can. I think it's such an important issue. So I think that burnout can kind of really stem from that, and one of the ways that I understand that is that sometimes when we think about stigma, it can be a way that a clinician is in a way kind of protecting themselves a little bit from that baggage of caring a lot about other people, and that can be hard. And I think this is kind of getting at that. And what I think is that we don't spend enough time, and when I say we, I mean researchers don't spend enough time thinking about this. So I think that's a real challenge, and I think that we need to get better in our training in terms of helping clinicians recognize that emotional weight that they can be taking on, and also kind of how to manage that. And so what I would say is I would really encourage you to kind of walk that maybe more difficult path where you still are trying to empathize, you're still trying to understand, but you're really kind of investing in strategies that help you do that in a sustainable way, where you're not taking on too much of weight, you're not kind of over personalizing. So related to the word empathy, you can think about cognitive empathy versus emotional empathy, and maybe it's something to look at in terms of how to think about taking on less of that emotional weight of this, and being able to kind of focus a bit more on the cognitive side of this in terms of understanding the cognitive aspect of it. Is just one little line of work that you might want to explore.
So we have time for just one more question. We had so many great questions coming in. So hopefully some of you guys can join us backstage when we move back there. The last question we have is from Adi, and she is in Israel. Where do you see the line between psychology and your model?
That's an interesting question. So I don't quite know how to answer that. So what I'm assuming here is that we're not all kind of have one clinical background. My background's in physical therapy. And a lot of what I focus on is kind of how we can address psychological factors, but within a scope of physical therapy. And so with my students, one of the ways that I would train them to do that is really to kind of focus on end goals. So from a physical therapy standpoint, our bread and butter is helping people become more active and reducing disability. And what we know from research is that there can be a lot of psychological barriers to that. And I try to teach my students how to address those barriers, but always thinking about the end goal. And so thinking about psychological factors as helping to decrease barriers to get at engagement in physical activity, to reduce disability. And so if that's your clinical background, if you're coming at this from a physical therapy standpoint, then that can be a strategy that you could use as well to think about that scope of practice issue. In terms of the model itself, I think that it's a little bit higher level than that. And I really think, coming back to the idea of how we're thinking about pain, is that we need to challenge ourselves to not only think about pain as sensory or emotional, but really kind of challenge ourselves to keep those two things together. Otherwise, it's not pain what we're talking about. And what I would say is that some of the ideas here in terms of giving space to understanding that lived experience of pain and the experience of pain, not just its symptoms, is I think just absolutely important for every professional. They're going to probably do that in different ways, but I really think it's important for all health professionals. Just before we wrap up, I just want to make a little plug for another presentation that's coming up on Sunday by Kat Glore. And Kat is somebody who's been living with pain, and she has just amazing talk That's Sunday at Eastern Time is 9 a.m. And the title is Seek First to Understand, Navigating the Language of Pain. And if this talk interested you at all, I think you'll be blown away by hers. And you can kind of think of it almost as this kind of first-person narrative, almost take on what I'm talking about here. And we didn't coordinate that at all, but we kind of just discovered through Rajam that was the case. And I really encourage you to check it out.